Hi, everyone, and welcome to our virtual health event with UC Health. My name is Hannah Schrepfer, and I am the Senior Event Coordinator here with the Highlands Ranch Community Association. We are so excited that you took the time out of your evening to join us to discuss Alzheimer's awareness. We are grateful for UC Health Highlands Ranch Hospital as a community partner and happy to host this wonderful event with their assistance. Before we get started, I would like to go over a few housekeeping items. We are recording the webinar this evening, and we will be sending that out via email by the end of the week. During the webinar, your microphones will be muted. To ask questions, please type them into your Q&A chat box located on the bottom of your screen in the control panel. We will save the questions for the Q&A portion towards the end of the event. Our presenter this evening is Dr. Wasserman. He is a general neurologist from UC Health who specializes in brain and nervous system. Now, without further ado, I'll pass the time off to Dr. Wasserman.
Hi, everyone. Thank you very much for joining me this evening, and I appreciate, as Hannah said, taking your time out to watch this. My name is Mark Wasserman. I'm a neurologist, a general neurologist with UC Health. I am originally from Flagstaff, Arizona. I went to college here in the Denver area and then did my medical school training in Milwaukee, Wisconsin. And then my residency, internship residency and fellowship all in Chicago at Rush and Loyola. And then came out to Phoenix for a few years, having gotten tired of the cold in Chicago. Got to Phoenix, thought, no, too far the other direction, it's too hot here, and then came back to Denver where I'm very happy. So I'm going to talk to you a little bit about Alzheimer's. We're going to talk a little bit about dementia in general, because a lot of people get dementia and Alzheimer's kind of mixed up. The best thing I can tell you just to start right away is that dementia is defined as any progressive neurological decline in memory, of which Alzheimer's is the most common type. So we'll talk more about that as we go. For information, I work out at UCHealth Sterling Ranch. Sterling Ranch is basically South Littleton. It's just west of Highlands Ranch. I am a resident of Highlands Ranch myself. It's about 10 minutes away. So please feel free if you have any general neurological questions and wish to see me. I am available out at UC Health Sterling Ranch. You can Google me, and the phone number out there is 303-265-3930, I believe. So let's talk a little bit about what dementia is. So dementia comes from the Latin. It literally means devoid of mind. And it is defined as a persistent state of cognitive, functional, and emotional decline from baseline. So in other words, it means that there is a decline from what the person used to be that is persistent, permanent. It doesn't come and go. And there's a number of things that can do that: strokes, infection, trauma, but most of the common types are degenerative. It's just sort of a slow decline in the person's ability to take care of themselves. And the key of dementia is that it cannot be from a delirium. So delirium is temporary. Somebody comes into the hospital, they've got a urinary tract infection, they're ill, they're sick, they've got COVID, they've got the flu, they're not thinking properly, they're confused. That's due to the infection. Get rid of the infection, they'll come back to baseline. That's delirium. Dementia means a slow progressive decline in memory despite any of that. There is no infection, there's nothing else going on, but their memory is steadily getting worse. And it's an increasing problem. From 1997 to 2015, this comes from the National Institute of Health, the population of those 65 and up in the United States increased from 63 million to 137 million. So the baby boomers going into this area now are twice as many people as used to be. It's a huge number of people. And of those people, 3% of those 65 to 74, 17% of those from 75 to 84, and almost a third of those 85 and up have some form of dementia. So it's a serious problem. How does it show up? Well, it's not usually the person themselves. There's sort of a joke in neurology that if somebody comes in and says, I think I have dementia, they almost never do. It's usually somebody brought in by their spouse, a family member who says, he's just not remembering things, and they have some sort of denial of it. The usual complaints that people talk about are like, they can't retain new information. I told them we're going to go somewhere tomorrow and it's just gone. They have trouble remembering events that they did, people's names that they should know, not somebody that they met 3 years ago and can't remember their name, but literally things like children of themselves, their spouse's name, friends of theirs. Having trouble with finances is a classic one. Being unable to cope well with any change in routine because it disrupts them. Getting lost on familiar routes, particularly driving. Repeating themselves multiple times. Word finding problems, just struggling to find the word. And changes in behavior, particularly sort of a paranoia. The most common one is that people are stealing from them when in fact they're losing objects. They're just misplacing them. And so they decide like, oh, well, it must be that someone took it. And the way that I like to describe it, although this is sort of a simplified version, is that the brain is kind of two structures. You've got gray matter. That's this ribbon on the outside, which is basically cognition. This is you. This is where you are in time and space. Who's the president? Where are you? What are you doing? What are your children's names? What are your plans? Gray matter. The interior of the brain, this darker looking on the MRI, although in the actual brain it's white, is called white matter. And the white matter is all the connections that the gray matter uses to process. And the white matter does get gummed up as we get older. So from things like smoking, diabetes, high cholesterol, concussions, drugs, even just age, the connections just aren't as quick. So white matter changes are I went in a room and forgot why I went in the room, and then I remembered later. I couldn't remember an actor's name, and then I remembered a few minutes later. Those are white matter changes common with age. Gray matter changes are much more like not being able to remember permanently someone's name or a date or an event. So this kind of goes into that. So when people ask, am I getting Alzheimer's? The age-related stuff that everybody comes into, I went into the room, I couldn't remember. I just have trouble. I'm not as fast as I used to be. I have trouble remembering things as quickly. Age-related. Concerning things are affecting daily life, inability to do new things, difficulty learning new things, trouble completing tasks that people used to be able to do, particularly finances. And in particular, other people are noticing this. So it's very hard when someone comes in sometimes to make that distinction. Sometimes you can do it pretty easily. Other times there seems to be like something wrong, but you can't quite put your finger on it. And that's something called mild cognitive impairment, which is this sort of intermediate state between normal cognition and dementia. There was actually a TV show on just recently, which just ended, called This Is Us. And the main character, the woman who, the matriarch of the family, had this. And they really did actually a good job of portraying mild cognitive impairment, like not quite dementia, still able to function, but not quite themselves either. And this is a weird state because some people will progress. About 15% of people with mild cognitive impairment will eventually get Alzheimer's. About 50% they stay like this for decades sometimes. And 35% get better. And the risk factors seem to be very variable. It has something to do with genetics, diabetic control, if you get that under better control, high blood pressure, stopping smoking, improving sleep, exercising more, education, and being active. So that you can actually affect the mild cognitive impairment bit a little bit. So again, to diagnose it, we basically get a history. Is this noticed by the person or family? What's the length of time? Can they function safely? What other medical conditions does this person have? Do they have stuff that they control? High blood pressure, diabetes? Have they had strokes, concussions, sleep apnea? Have they had a heart bypass, which interestingly seems to affect the way the brain functions in the long term at a minor level? What medications are they on? Sometimes people will come in and they're loaded up on sedatives. You're like, well, no wonder they're not thinking clearly, and you have to kind of adjust those meds. Is there a family history? Do they smoke? Did they ever smoke? Did they use drugs? Did they used to drink heavily? Were there exposures at their work? Where did they grow up? Were they in an area that's known for toxins, that sort of thing? We do a physical exam, but to be perfectly honest, in Alzheimer's, the actual exam of the person is often surprisingly normal because it doesn't affect things like motor function, sensory function. You can see some signs of Parkinson's in certain types of dementia. Some people have a sudden startle reflex, but for the most part, most people with Alzheimer's have a totally normal exam physically. So how do you get at it? Well, we do a couple of assessments in the office. There's different tests you can do that are kind of screening tests. So there's the mini mental state exam. There's something called the MOCA, which is used more in Canada. And the animal naming test, which is a surprisingly accurate test where you just say, name as many animals as you can in a minute, and you count. And surprisingly, normal is 15. You'd think that it would be more, but it isn't. And people with dementia have trouble even getting to sometimes 7, 8 different animals. And then people who have normal memory, they often can get easily above 15 to 20. My record is 41, which I was very impressed by. So this is the mini mental state exam. It's not that important to know what's in this, but you can kind of tell, like, what's the year, what's the day, what state are we in? Name these objects, spell the word world backwards, name this object, repeat this, draw this, name these animals. Those sort of things can often be like kind of get at how their memory is. But we still do more of a workup. So the classic workup is usually to do a scan of the brain, particularly to look for that gray and white matter issue. And also things like the pattern. Is there an atrophy pattern, which you can sometimes see in Alzheimer's? You'll see atrophy of the temporal lobes, which are the area that actually does memory. Is there water on the brain? Is the fluid not circulating properly? Have they had multiple strokes? Do they have a brain tumor, which can happen? Do they have a bleed? Did they hit their head years ago and have sort of what's called a subdural? Is there something you can reverse? An EEG, which is done a little depending on the history. That's looking for seizure activity. So when there's a few hallmark things like the person staring off into space, not responding, making odd twitching, repeating themselves over and over in kind of an automatic way, we'll often do an EEG. Surprisingly, seizures can sometimes present as memory problems and are treatable. So an EEG is very helpful. That's just basically putting probes on the head and monitoring the brain waves, looking for those discharges of abnormal neurons. And it's painless and surprisingly accurate. Lab testing, looking for other things that can affect memory, like anemia, liver or kidney problems. These are the labs themselves: thyroid problems, vitamin B12, vitamin B1, heavy metals, and RPR, which looks for syphilis. That actually used to be more of a problem in the 70s and 80s. You don't see syphilis so much anymore. PET scans, although those are not often done, not that they wouldn't be extremely helpful. PET scans show the function of the brain. They can often tell you for sure the person has Alzheimer's. So of course, Medicare doesn't pay for it. We've tried multiple times. Sometimes Medicare will, if you really force the issue or if it's confusing, but they're just hard to get. There are ways to look at the amount of tau in the brain. So we'll get into this in a little bit, but Alzheimer's, there is a waste product that the brain produces called amyloid. And amyloid is supposed to be sort of flushed out of the system. It deposits in the brain in kind of a normal way, but in Alzheimer's, for some reason, it deposits particularly in the temporal regions that do memory, and it seems to tangle up the neurons there. So you can actually do a spinal fluid test looking for the amyloid ratio. And if it's depositing up in the brain, you don't see as much in the spinal fluid. And so that's an indicative test for Alzheimer's. The problem is it's a spinal tap. It's pretty invasive for something you can't really do anything about. So it's not very often done, but there is that fairly definitive test for it. We'll get a little into the amyloid hypothesis in a bit. Is the deposition of amyloid in the temporal lobes what causes Alzheimer's, or is it just a symptom that you see in people who have Alzheimer's, which has not been very well established yet? The ultimate way to do it outside a PET scan and spinal fluids and such is something called a neuropsychological evaluation, which is a much more detailed memory test than the mini mental state can produce. It looks at all kinds of things: memory, attention, orientation, visuospatial skills. Some of it is even trivia. It's just a sense of like how the brain is working. And it's very good at picking up true Alzheimer's versus other types of dementia, depression, which can look like dementia, post-traumatic stress disorder, ADHD. It's very good at picking up all of those. So this is an invaluable test. The problem is that neuropsychologists are so in demand now that they can be booked out months trying to get this test. So you're still a little stuck for a while trying to make the diagnosis. So let's talk a little bit about Alzheimer's. So as I said, dementia is any progressive loss of memory, of which the most common dementia is Alzheimer's. It's by far the most common. It's 75% or more, and it is now the 5th leading cause of death in the United States. It was described way back in 1907 by this guy, Alois Alzheimer, who named it after himself. And he found it in a 51-year-old woman with memory impairment, and noticed the amyloid plaques, these amyloid depositions on autopsy, which was more in the temporal lobes. And so he thought, okay, well, that's what's causing Alzheimer's. What's kind of ironic about that is that, this woman was 51. This is actually probably a very unusual case of Alzheimer's. She actually probably had a genetic version because she was so young. And so that's a little bit atypical, but nonetheless, it got named after him. People always come in saying, if they have Alzheimer's, like, well, is this genetic? Alzheimer's is common. The genetic ones actually aren't so common. There are genes that increase your risk of getting it, but it doesn't necessarily mean you'll get it. The most common one is called ApoE4. And you can test for ApoE4, and it tells you have about 20% increased risk of developing Alzheimer's. But that doesn't really help you. And my feeling has always been like, all it does is make the person believe every time they misplace their keys that they're getting Alzheimer's. And it doesn't really help very much. The genetic ones, most people are getting it in the family. Lots of people are getting it, and they all get it in their 50s and 60s. Whereas like the Alzheimer's you see more commonly, the non-genetic ones, are up in the 70s and 80s. Those typically are more spontaneous, not genetic. And in fact, advancing age is the most common risk factor. So the genetics, at least for most Alzheimer's, are less important. And they're also a bit of a function of you can make it worse yourself. If you've got high blood pressure, diabetes, if you're not taking care of yourself, you actually increase your risk of getting this. And it's slightly more common in women, but that's probably age. Women live longer, so they're just more likely to get Alzheimer's. So it almost always presents, as I said, with short-term episodic memory, repeating questions, as we said, because episodic memory like that is run by the temporal regions. It can affect naming, facts about the world as well. Neuropsychiatric symptoms, you see with this a lot, something called sundowning. So the person's okay during the day, and then sundown hits, and it's sort of the lack of light disorients them a bit. They get worsening mood, depression, anxiety as the sun sets, poor eating, sleeping more during the day, not sleeping at night, often the opposite of their prior behavior. So if they were calm, relaxed individuals, they might become more agitated. If they were kind of agitated, angry individuals, they tend to become more calm. It's kind of an interesting phenomenon. Paranoia, as I mentioned, not typically hallucinations, not seeing things that aren't there, but believing things have happened. There was someone at the door. My child was here earlier, that kind of thing. So these are those tangles, and it's the black thing. It's exactly what you'd expect it to be. It's this tau protein that gets phosphorylated and soluble. Those are the tangles, and they're tangled up with this amyloid protein. This is an actual PET scan, and this shows the actual uptake of glucose into the brain. And in Alzheimer's, in the temporal regions, which are here and here, blue is decreased uptake. All that amyloid prevents glucose from getting in there so that the brain can function properly. The question I'm sure you're going to ask is, well, you know, can you give glucose and make up for that? And unfortunately, you can't. There was actually a drug called Exona. It was a food, and the idea was to increase the amount of ketones so that the brain had this alternative energy source and would get it more in the temporal lobes. And unfortunately, it just didn't work. They've been trying it, but it doesn't seem to help. So what treatments do we have? Well, there's a few things you can do. There's a brain chemical called acetylcholine. And acetylcholine is the chemical that the synapses use to communicate with one another. And you can actually increase the amount of acetylcholine available by giving an acetylcholinesterase inhibitor, which is a fancy word for saying you remove the thing that gets rid of the acetylcholine so that more acetylcholine stays in the synapses. The classic drugs for that are donepezil, which is the brand name Aricept, rivastigmine, which goes under Exelon, which is actually a patch, and galantamine, less used, called Remenil. It kind of puts the brakes on things for a time. It doesn't really change it that much, but it seems to slow it down a little. It can cause nausea, so that's its big limiting factor. It varies. Some people notice a tremendous improvement on Aricept. Other people, nothing seems to happen, but we continue them on it anyway because it does seem to help slow down the progression of the disease slightly. There's also something called a glutamate receptor modulator called the mantine, which seems to kind of stabilize the amount of cell death caused by the amyloid and tangles. And they actually work rather well in combination if they don't cause nausea. We'll sometimes use the antidepressants, not for depression, but because it boosts other brain chemicals like serotonin and norepinephrine. And antipsychotics can be used for the agitation, paranoia, although they do have a black box warning, which was found recently that they actually increase the risk of cardiac problems. So we're pretty careful about that. If the person has cardiac disease, it's really risky to use these. And sometimes you're forced to, the person's a danger to themselves or others, but we're more inclined to use them if the person has no particular history of heart problems. Another reason to keep the heart healthy. Probably many of you have heard of this new drug, Aduhelm. Aducanumab is the generic for that. The idea of these drugs is they take out the amyloid. They basically get into the brain, they remove that amyloid deposition. In doing so, at least with Aduhelm, 4 out of 10 cases had brain swelling. Now, nobody died, or actually one person died, but she was very ill. And the drug company's argument is, well, it works and nobody died. My feeling on that is, you still got brain swelling, you're still in the hospital, it's still not great. And also the tests that they used for this were very, very vague. So there were 2 tests that they looked at, kind of based on that mini mental state exam, called Emerge and Engage. And one of the tests showed no difference with Aduhelm, and one of them showed an improvement of like 0.45 on the highest dose. The mini mental state exam is a 30-point exam. 0.45 of a degree is so small that whether or not that makes any meaningful clinical difference for a drug that originally cost $56,000 a year is questionable. To the point that Medicare actually said, look, we will approve this drug's use, but only in the setting of a clinical trial. We really need it to be tested for longer to see if in fact it works. And so to this day, it's very uncommonly prescribed outside those clinical trials, which honestly is probably appropriate because it really isn't clear that it works. And something that costs $56K a year, you'd expect it to work. There are alternatives being researched. The most interesting one of those right now is as you can tell from the name, related lecanemab, which interestingly is made by the very same company, Biogen. It looks a little more promising. There's less brain swelling. It might help a little more, but it's still very small. And the question is whether or not that's clinically significant. This is a personal opinion, and this is not endorsed by anyone else, but a lot of neurologists think that the amyloid hypothesis that this is based on is wrong. That the amyloid is a byproduct of something else going on, and that removing the amyloid from the brain is a bit like hammering a nail into a board and then removing the nail and saying, see, the board is better. The damage is already done. And so the question is like, well, why is it being nailed in the first place? Like who's hammering? What is the cause of that? So that's my feeling on it. But obviously there's a lot of research and money going still into the amyloid hypothesis. Whether that'll continue, probably based on the efficacy of these drugs. So alternative Alzheimer's, as I said, Alzheimer's represents about 75% of dementia. The next 20%, like this covers like 95% of dementia, is vascular. And vascular is from strokes. It's hardening of the arteries in the brain. And the way it looks different is that the multiple strokes begin to cause the loss of memory. So it's this very stepwise deficit. It's not progressive. It's not this sort of slow decline over years. The person has sort of abrupt declines, like a stairway. The most common deficit is language. And the memory problems, obviously, each time there's a stroke, they get worse. And the way you can kind of tell that is that unlike Alzheimer's, there are motor and sensory problems with a stroke. And so if there's motor or sensory abnormalities on the exam, you're more likely dealing with vascular dementia. And the key is preventing the next stroke so that they at least stay on the plateau that they're on. So this is vascular dementia. You remember that white matter in that previous one? This is blasted away white matter. You've basically just got hits of multiple strokes over time. In this case, from high blood pressure. But diabetes, smoking, all of that can produce that. And the white matter disease becomes so severe that even though the gray matter, the cognitive stuff is working, it just can't get through. There's no connections. And so the person begins to lose their memory with each subsequent stroke. So how do you prevent it? You prevent the next stroke. You get that blood pressure down. You tell the person you got to stop smoking. You get the cholesterol, the goal LDL. The previous one said less than 100. There are some studies now that actually look at it being less than 70. Daily aspirin, surprisingly helpful, or other anticoagulant, depending on risk factors. Statin drugs, which are very helpful for lowering cholesterol. Something called the MIND diet, which is very heavy on vegetables, fruit, olive oil, and regular sleep and exercise. There's also a thing called Lewy body dementia. This mentions 20% of dementias, and I put it in there. I've never seen it be that high. Most of us believe it's actually smaller than that. And it's probably because it actually has some overlap with Alzheimer's. You can see people with both of these, but it tends to progress more slowly. Alzheimer's runs about 10 years. Lewy body can go up to about 20. The genetics of it are not well understood. It may not be present at all. It shows up like Alzheimer's when it begins, but there's a few little quirks that are different. Attention seems to be more of a problem. The person has more dramatic fluctuations. They'll be better one day, worse the next. It's a little bit they have good days and bad days, which is not necessarily the case in Alzheimer's. Hallucinations, actually seeing things that aren't there, rather than just delusions, is much more prominent. And there's a slight Parkinsonian feature to it. often that little tremor, sort of a flat face can be there, but it's very mild and it can be very hard to tell which of these it is. Lewy bodies are another deposition product. So instead of tau depositing in the temporal lobes, you get these Lewy bodies, which are made of alpha-synuclein. It's another different waste product. It's exactly the same product that shows up in Parkinson's, but in Parkinson's, you're losing it in the midbrain. Here, it's in the temporal regions. Treatment, very much the same. Acetylcholinesterase inhibitors. So if you get it wrong and you think it's Alzheimer's and you put them on Aricept, they'll do fine. And in fact, weirdly, they do better. The Lewy body patients on those acetylcholinesterase inhibitors actually do quite well, and it seems to slow things down for a longer period. You can do mild Parkinson's medication, which kind of help with the movement issues. Antipsychotics, same problem, controversial. And interestingly, in Lewy body, it actually makes things worse. So we really try and avoid those in this version in particular. Couple other real minor ones I'm going to go into just to kind of complete our understanding of dementia. Frontotemporal dementia. Most neurologists only see a few cases of this in years. It was originally called Pick's disease. It was described in 1892 by this Arnold Pick, who just never caught on as big as Alzheimer. There's actually a movement now to rename these things for the disease process rather than the person who discovered it, just because it's not very helpful to tell somebody you have, Smith's disease. It doesn't really, it's not very descriptive. So Pick's disease is almost always called frontotemporal dementia now. Alzheimer's is so embedded in the name and society that that's not going anywhere. Same with Parkinson's. But a lot of the rarer diseases are no longer named for the person who they were named after in the first place. Particularly as a few of them have turned out to be, there was one case where we had to remove the name because the person turned out to be a Nazi, and that was discovered in the 70s. And so we decided that that was not a good idea to name the disease after him. And so the name was removed. Pick's disease tends to show up much earlier, like in the 50s, and it's very behaviorally dominant. The person is really socially inappropriate, weird declines in hygiene, obsessive compulsive disorder, paranoia, trouble talking, and unfortunately, it has a much worse prognosis. It goes faster. People tend to get themselves injured. It's a really nasty disease, but luckily it's rare. It's exactly the same as Alzheimer's with the tau, but it's this weird mutated form that isn't well understood when people get it. There's another called normal pressure hydrocephalus, and we're always looking for this because it's at least partly reversible. In the brain, there is spinal fluid, and every day you are producing about 150 milliliters of spinal fluid, which coats the brain and protects it. So if you bump your head, the brain kind of floats in there. And every day we're making 150 milliliters and we're absorbing 150 milliliters. And there are people who, for whatever reason, scarring, other issues, the fluid they're either making a little too much a day or not absorbing enough a day. And we're talking a tiny, tiny bit. But over the course of years and years and years, the fluid starts to build up. And so what you see is the ventricles, the interior of the brain where the fluid is starting to push outward against the brain. Some of the first signs of it are a slow progressive headache and darkening of the vision, particularly big dark floaters in the vision. And if you have an eye exam, they can actually see swelling of the back of the eye because the fluid is pushing on the eyes, and you can see that in the back. When that fluid comes out, it tends to hit the fibers that run the legs. And so the classic findings of it are what we call the triple W. They're wet, they're incontinent, wobbly, they're unsteady, and they're weird. They're just, their memory is not right. And that's the classic triad, this gait instability, memory problems, incontinence, that looks a bit like Alzheimer's, except for those additional features. And when you look at the brain, you got these huge ventricles in the middle, and to the point that the normal folds of the brain are kind of pushed outward to the outside. The treatment for that is a spinal tap. You can actually do a spinal tap, take out a lot of the fluid, and then have a physical therapist check them before and after and see if they're better. And it can be very difficult to diagnose, but occasionally we've all seen cases where you take out 40 cc's of fluid and they're remarkably better. And the treatment you do is something called a shunt, which you can actually put in something in the body that sort of shunts the fluid constantly out at a very, very mild level so that things are back in balance again. And you can adjust the shunt to get the right amount. A neurosurgeon can do that. It's not totally benign. I mean, you're putting something in the brain. There's a risk of infection, but when it works, it really works. I'm going to talk about one other, just to scare everybody. Prion disease, also called Creutzfeldt-Jakob disease, but again, you probably won't hear Creutzfeldt-Jakob much anymore, is related to mad cow disease in the United Kingdom. It's never been reported here due to eating infected hamburger. Every case here in the United States has been spontaneous, and it causes a problem with a protein in the brain called the prion. And the prion is a structural protein. So when prions are damaged, they actually start to fall apart and you get holes in the brain. So it's Swiss cheese brain, it's terrifying. We don't really know, just to make it worse, whether it's infectious or genetic. It seems to come on just spontaneously. It is luckily extremely rare. I have seen one case. I've been doing this for 15 years. Most of us see maybe one or two, in a career, if that. But the classic finding of it is rapid progressive dementia over the course of about 6 months. So the case that I saw with this was I was working as a resident and I was called to the psychiatric unit to see a patient. And it's a classic thing about neurologists that we just hate that, because it's basically you're going in, they're having you see a psychiatric patient to show that it's not a neurologic condition, right? So they basically want to prove that the schizophrenia or the bipolar disorder or what have you is not due to something in the brain. And so you end up doing the same thing every time, an MRI of the brain, an EEG, you say, okay, no, it doesn't seem to be anything brain activity. And they say, thank you. And that's the end of it. So I got called for, rather unusually, a 75-year-old man. And I went in and he was extremely confused and very, very agitated. And I talked to the family and I said, well, how long has this been going on? And they said, well, it was like September. They said, well, since June. And I said, well, what do you mean since June? I mean, anything before that? Like, no, he was, running a bank in May. He was perfectly fine. And then in June, he just started to decline and now he's in a psych unit. And I'm like, that's a little weird. Is there any psychiatric history? And I'm like, no, he was, very respected member of his community. He's got 3 kids who adore him. This is completely out of character for him. So I did an MRI on him and you can actually see an abnormal signal that's typical of this. And then I did an EEG, which shows the particular characteristics, something called periodic spikes. And then finally, you can do a spinal tap for this protein called 1433, which isn't specific for CJD, but is so commonly seen in it. And he had all 3. So, it didn't help exactly. I mean, he still, died in about 4 months, which unfortunately this disease does do. But at least the family knew that he didn't suddenly go insane. It wasn't some psychiatric breakdown that they had to worry about genetically. This was a neurologic disease and not genetic, and very sad, but unlikely to affect anybody else. So this is an actual histological image of it, and you can see the holes. The proteins actually break down, and this is something called Swiss cheese brain. And we saw a lot of, when I trained in Milwaukee, we saw a lot of Swiss cheese brain. Here's a particular bad case of that. So, okay, so what can you do? Well, Alzheimer's is irreversible. We don't have much choice there, but there are things you can do to not only try and stave it off in the first place, but if and when you were to get a diagnosis of dementia, to slow it down. So things like learning a new skill, keeping the brain active. So those horrible nursing homes you see where people are just staring at TVs, that just accelerates the problem. You want to be able to keep the person's brain functioning, making new neurons, which it does do. We didn't think it did for a long time. Learn new skills, read regularly, plan tasks, make to-do lists, use memory calendars, use notes. The person has trouble with routine, they put it in a calendar, it becomes the routine. Put your wallet, purse, keys, phones, glasses, things like that, same place every day. Don't leave your phone sitting around. We all do that. We all lose our phone. But for a person starting to suffer from dementia, it's a real problem. Put your phone down, put it in the same place every time. Stay involved with volunteering activities that can help the mind, help the body. Spend time with friends, family. Sounds cliched, but it actually keeps the mind active. Get enough sleep. We recommend more than 7 hours a night. If you are snoring or gasping for air, that can be a sign of sleep apnea, which is treatable and should be looked into. Exercise, regular exercise, 30 minutes a day on average. Hard to do, I know, believe me. But the more you can do, even just getting out, walking the dog, get a dog, remarkable help. Eat well, mind diet. Supplements, there's a few supplements that have been shown to be helpful in some cases. Turmeric is one. It's actually the active ingredient in Indian food. And interestingly, the rate of Alzheimer's, despite the population of India, is smaller than you'd expect. And there's some suspicion that some of the spices, which have an anti-inflammatory effect there, are helpful. CoQ10, which is the enzyme that the mitochondria, the energy source of the cell, uses, seems to help. It is unfortunately expensive and the dosing is not very clear, but there does seem to be some effect from it. Fish oil and coconut oil in small studies have been shown to be helpful. A couple things that are not helpful, and we usually tell people to avoid it. Vitamin E, for a long time we thought that helped dementia, and it unfortunately also increases the risk of heart attacks. So we usually recommend no, excess amounts of vitamin E, and particularly ginkgo, which has been known for years to be used for memory. It's a Chinese supplement. It was used in herbal medications. Unfortunately, there's some evidence that it not only doesn't help memory, but can actually increase the risk of brain bleeding. So we tend to warn people against ginkgo. Privigen is all over the commercials and such. And the idea of Privigen is sound. You're basically giving lipids, and lipids stabilize the neurons. The problem is that it's not clear whether or not those lipids actually get into the brain. And so as a result, whether or not that helps is questionable. Probably doesn't hurt, but it doesn't help. Absolutely control risk factors. So like hypertension, high blood pressure, blasts away at the brain, can increase the risk of vascular dementia. You want that below 140/90. Diabetes is exactly the same way. Glucose is sticky. It damages the neurons. You want those sugars under good control, regular control. Eat right. Use insulin if you need insulin or medications. Don't drink excess alcohol. Alcohol is kind of an interesting one because there's some evidence that a small amount of alcohol, particularly red wine, may actually be helpful. Same with coffee. But in excess, it causes the opposite problem. So more than 2 drinks a day is been linked to dementia, and you want to avoid it. And this is of any type of drink, particularly hard alcohol, which actually counts as 2 drinks. So no more than 1 a day. And particularly if you have any history of alcoholism, it needs to be avoided altogether. Don't smoke. Smoking is disastrous to those arteries of the brain. It causes hardening, it causes strokes, it reduces the amount of oxygen available to the brain. Absolutely, if you are smoking, you are increasing your risk. You need to stop. And same with illicit drugs, not typically as much of a problem in 70-year-olds, but cocaine, and surprisingly, marijuana. It's not that marijuana causes any damage to the brain. It doesn't. And it does help with pain and things like that. But as you know, it is somewhat sedating, and people kind of feel a little bit high on it, particularly if they're using the THC version. The CBD version is probably harmless, but if there's THC in there and the person's getting high, it affects memory. And so we do tell people to try and avoid it as much as possible. Obviously, cocaine, more danger. And get help if you feel depressed. We see a lot of what we call pseudo dementia, which is essentially that the person isn't actually suffering from dementia, they're suffering from depression. They, have lost family members as they get older, or friends. They may not have the independence that they used to. They may feel a little bit isolated, and there's sort of a sense in some people of giving up. And so when you ask people the day, date, their year, they know it, they just don't sort of care. And you can give antidepressants in that situation, but what really helps is things like getting the person out there, getting them active again. Counseling can be extremely helpful. And obviously, if you're feeling suicidal, using the suicide hotline. They recently changed that you could actually dial 988 and go directly to the suicide hotline rather than remembering the old number. So that can be very helpful if you've got somebody who is suicidally depressed. The elderly are not immune to suicidality. And so it is something we have to keep an eye out for. And we always screen for depression in our clinic for just that reason. As far as safety goes, if you are taking care of somebody with dementia, ensuring basic needs are met so that they're oriented, creating a daily plan, regular routine, deadbolts on doors so people don't wander off, night lights so that if they go to the bathroom, they can see where they're going and don't hit anything or get confused or lost, medication planners, stove knob covers so they're not turning on the stove, kitchen safety in general, making sure that they can't leave the gas on, removing loose rugs, which are a risk factor for falls, keeping an eye on finances and sadly scams, which are becoming more and more common and not only hitting the elderly. People have lost hundreds of thousands of dollars to these scammers. And driving safety, which is a tricky one because we live in a state that is not a reporting state. You can't report someone saying their memory isn't working. It's usually the family that has to report it. So looking out for unexplained accidents or getting lost on what should be a perfectly familiar route are signs that the person might need to give up driving. Here are some resources that I like that I usually give to patients. The classic one is the Alzheimer's Association, alz.org. They actually have a 24-hour hotline that you can call. And they're very, very helpful. They have all kinds of resources. They can connect you with Medicare and things that pay for this sort of respite care and placement issues and things like that. Surprisingly, there's a hotline that a lot of people don't know about called 211. It's run by the United Way. You just dial 211 on your phone and it will connect you to a social worker who can help with placement issues and social work and respite care and even just talk to you if you're having a bad time. There are elder care facilities all over Colorado of different styles and types. If you dial this 800-677-1116 number, they can help you with some of those and how to pay for it and what is available out there, including home care, if that is more of an interest to you, or hospice if the person doesn't have much longer to go and has other issues. Books that I tell patients are helpful. My favorite of all of them is the 36-Hour Day. It's very readable, and it really talks about like how a person with Alzheimer's thinks, how to take care of them, what to say when they're confused. Do you kind of agree with their confusion or do you argue with them? That sort of thing. How to cope day to day with losing the memory of someone you obviously loved. My Two Elaines is a beautiful book. It's by this guy, Martin Schreiber, who wrote about his wife, Elaine, who died of Alzheimer's, and kind of the dichotomy that he would see between his, normal wife and the woman that unfortunately developed Alzheimer's and is not the woman that he married anymore, and kind of how he sort of coped with that. Learning to Speak Alzheimer's. I have actually not read this book, but I've heard good things about it by Joanne Cost. Kind of the same idea, like how do you talk with somebody with Alzheimer's? How do you interact with someone who doesn't understand the world around them? And then the similar Surviving Alzheimer's by Paula Scott. There's a number of books out there, but I really feel like these four kind of capture the pain and the difficulty of taking care of someone with dementia who unfortunately is just not the person that they used to be, which could be just devastating for family members. And as I said, unfortunately becoming more and more common as people get older. So thank you very much. And I'm ahead of schedule a little bit, but I'm free to open this to questions.
Yes, thank you, Dr. Wasserman. We will now go ahead and take some time for questions. And I do see we already have a few. The first question for you is, my father has been diagnosed with Alzheimer's. Where can I get a genetic test to see if I have the gene?
Okay, so this is kind of what we talked about earlier. So the thing with the gene, the ApoE4 gene, is that all it will tell you is if you have it, that you have an increased risk of getting it, about 20%. It does not tell you that you'll get it. So you have to kind of keep in mind, is this going to be helpful for you? If you have this gene and you know that you have an increased risk of getting Alzheimer's, but not that you necessarily will, what do you do with that information? Does it change anything you do day to day? Because there are no treatments, unfortunately, for prevention of Alzheimer's. And the sort of thing to prevent Alzheimer's from occurring, eating well, sleeping well, exercising well, are honestly things you should be doing anyway, regardless of whether or not you have that gene. So you'd have to ask yourself first, do I really want this gene test? If you decide, yeah, I just want to know, there are a couple of ways around it, but surprisingly the easiest one, and you can do this through a family practitioner or through a neurologist, is that ApoE4 is a lipid. And so if you get a lipid panel, there are certain lipid panels that check for cholesterol that also happen to check for ApoE4. And so you can see if the level is elevated, and that tells you if you have that gene. There are also specific gene testing for it through various sites. And so they can test for it directly through a lab. And you can actually talk to either a family practitioner or a neurologist, and they can just kind of order it for you. But again, before you do it, I would just, question yourself, like, well, what do I do with this information? Should it be positive? And by the way, just because it's negative doesn't mean won't get Alzheimer's either. So it's a questionable test, essentially.
Great, thank you. The next question is actually for me. Will we be able to watch this recording again? The answer is yes. We will be sending that out to everyone on this webinar and everyone that registered but wasn't able to attend via email by the end of the week.
And as I said, if you want to contact me directly, I'm down at UCHealth Sterling Ranch at Piney River Avenue, just off 85, just southwest of Highlands Ranch. So feel free to make an appointment if you want to talk to me personally.
Awesome. And then the next question we have for you is, there is intriguing evidence that suggests that increasing L-serine in the diet may reduce the risk of developing Alzheimer's. There is a phase 2 study that just started in Houston looking at the effect of L-serine in PTS with MCI in reducing the risk of progression. Any thoughts?
Yeah, I've heard of this too. It's interesting. It's an amino acid. So again, not entirely clear how it's getting in the brain or whether or not that truly helps, but it is intriguing. And of course, any studies that look at this have been helpful. It's an amino acid. It's not going to do any harm. I haven't seen any specific studies yet stating it, but I've heard about that as well. I didn't throw it in because it's still a little speculative at this point. But yes, I've also heard of that.
Great, thank you. And next question, if a patient with dementia goes under anesthesia, can that cause long-term exacerbation of the dementia?
So I haven't seen studies showing it. We all know that it's the case. This kind of goes to the cardiac bypass thing that I mentioned, where there's something about diverting blood in the cardiac bypass and something about certain anesthesias and being under that seem to affect the brain at some level in some people. Obviously, sometimes you don't have a choice, right? I mean, you need to have a surgery, you need to have a surgery. But there probably is some risk. I don't know that there's any quantified amount of risk, and there are probably some anesthetics that are safer than others because they're shorter acting. So, for instance, etomidate and propofol are very short acting anesthetics and probably have less risk than some of the more sedating ones that used to be used. So it is something like if you're worried about mild cognitive impairment and you have to have a surgery, it probably is worth talking with the anesthesiologist about this and seeing if you can use the shortest acting, gentlest ones possible that will still allow the surgery to occur. But if I had mild cognitive impairment, I probably wouldn't be doing elective surgeries for just that reason.
Great, thank you. Next question, why is it important to get Alzheimer's diagnosed?
More for prognosis. You're right. I mean, it is sort of frustrating. I had a patient once, I see people with Alzheimer's about every 6 months, right? And they came in and they're like, I don't know why we see you. He's good and declining, keeps declining. He's not getting better. Why do we keep coming in? And it's a good question, but the truth is that some things do change. You could get psychotic behaviors that can be treated with antipsychotics. You could get what's called pseudobulbar affect, which is unusual sort of laughing in inappropriate times or crying at inappropriate times that's treatable. But a lot of it, honestly, is because of the prognosis, right? So if you have somebody who you now know has Alzheimer's or will be developing Alzheimer's, you can start to plan. Many of the nursing homes are booked out for years. There's a huge financial burden involved. And there's things that just come into play, like legal questions. So who has power of attorney of their medical decisions when they're no longer able to make medical decisions? Who is making power of attorney over their financial decisions when they can't do that anymore? It needs to be somebody who's a family member or a trusted friend who you trust to do that, or the person can start making his mistakes and have nobody to fall back on and become victim of scams or other issues. So if you know that a loved one is developing Alzheimer's, you can start to put all that into play. You can get an elderly lawyer involved, you can get planning involved. And to some extent, you now know, we've got another 10 years, probably 5 years where mom is still herself. And enjoy that time as much as possible before the disease kicks in versus not knowing what's happening that whole time and then diagnosing it at the last minute, at which point it's too late. So while there isn't a lot that can be done right now, I still think it's important to diagnose it. The other thing is that with these new drugs coming out, there are going to be treatments available. I don't know exactly when. I don't think there's going to be a cure anytime soon. But I think it will get to the point where we're able to say, look, she has Alzheimer's or he has Alzheimer's, and there are drugs that we can give right now that will slow this process down. Let's start it. We're not there yet, but I would imagine within the next 5 years we will be.
Great answer, thank you. Next question, is Lewy body dementia hereditary?
We don't know. There are Parkinson's, which is based on the same disease that Lewy bodies is, to a mild extent. So there's probably some assumption that Lewy body is. If it is genetic, it's not very strongly genetic. It's not like you're going to get it as a guarantee. We all think of diseases as oh, mom had it, so I'm going to get it. And most diseases actually aren't like that. Those are what's called autosomal dominant diseases, the classic example being Huntington's disease, which affected the Guthries. That one you can actually test for and be sure that the person is or is not going to get affected by it. Most diseases, there's not only genetic factors involved that put you at higher risk, but there's a lot of environmental factors that go into it that may or may not cause the genes to kick in. And so there's a lot of factors that play into it, Lewy body in particular. And so we don't really know exactly what kicks that off or whether or not the next person is more likely to get it. I can tell you that every case I've personally seen of Lewy body, it's an isolated case. I've certainly seen families where Alzheimer's crops up over and over and over in multiple family members. Lewy body, you just don't see multiple people with family members coming in with Lewy body. It seems to be kind of an isolated thing, or at least I have not.
Great, thank you. And next and last question. I presume that the rate of decline is different for all patients. Do all Alzheimer's cases cause progress to the same degree and bearing unforeseen issues such as death?
They all progress. So Alzheimer's is relentless. It does progress in everybody. However, the rate of that progression does vary. The average is about 10 years from the time of diagnosis, with the first 3 years being kind of mild, the next 3 being sort of moderate, and the last 3 fairly severe. That does vary. I've certainly seen Alzheimer's patients who have declined a lot faster within a few years, and some who have taken, upwards of 15 years. But the sad thing is, once the person is diagnosed with Alzheimer's, it doesn't just sort of stay the same. And if it is staying the same, you'd have to question whether or not they're right about the diagnosis of Alzheimer's in the first place, whether it's still mild cognitive impairment or whether it's vascular dementia and there's just sitting on a plateau, or Lewy body and is slow. That's more likely. I've sadly never seen an Alzheimer's patient beyond 15 years of diagnosis. It just doesn't happen for 2 reasons, not just the disease, but because Alzheimer's is often a disease of the elderly. And so, if someone comes in at 84 and is diagnosed with Alzheimer's and they have 10 to 12 years, well, they may die of something else at 91 rather than the Alzheimer's. So there's factors that come into play, but no, unfortunately, once you're diagnosed with that, that's it. It continues to decline from there.
Great, thank you. Thank you for answering all those questions. Friendly reminder, this webinar has been recorded and we'll be sending out the recording by email by the end of the week. Thank you again to UC Health for giving us the opportunity to learn about Alzheimer's awareness from Dr. Wasserman. And thank you to all of those who joined us tonight. Our next virtual health event will be on Wednesday, January 11th on Nutrition 101. Thank you again for joining and have a great rest of your night.
Good night, everyone. Thank you so much.